Hi, everyone. Thank you so much to SAGES for the opportunity to present in this preoperative optimization format. My topic today is talking about what should preoperative optimization be and how can we affect outcomes for our patients. These are my disclosures. I will state that both the funding from Blue Cross and Blue Shield and AHRQ directly resulted from this work. However, it should not bias my opinions. So I think one of the questions that remain in surgery today is how do we really improve quality? Oftentimes we talk about technique and improving technique in perioperative care, but we don't spend enough time talking about our patients and thinking about how can we get them to surgery and through surgery as safely as possible. If you think about surgery as a marathon, we really need to spend time training our patients to get through this essentially insult to their bodies and help them recover better. In this context, we talk about preoperative optimization, which is also sometimes referred to as prehabilitation. And more or less, this essentially means the mitigation of patient risks prior to surgery. And we note from many meta-analyses and papers that delaying surgery and managing risk factors prior to surgery can really reduce surgical complication rates in up to 40% of persons undergoing operative abdominal procedures. Here you can see a meta-analysis that was published basically showing the overall impact of prehabilitation on patient outcomes. However, what do we know? What are those factors that really do increase the risk for morbidity? Diabetes with poor glycemic control, obesity, smoking, substance use, collagen vascular disorders, chronic immunosuppression, women of childbearing age, gender, and a whole slew of other factors can increase the morbidity of surgery. I've started some here because I really want to make the point that while there are some factors that are not within our control, we can't change somebody's age or gender, we can do something about those things that are modifiable or within our control. I'm going to use hernia and some of the work we've done here as a case study to sort of think about that and how do you go about identifying and implementing changes that would improve the care of patients. So for one study where we looked at this, we looked with our Michigan Surgical Quality Collaborative, which is essentially a statewide registry which prospectively captures data from patients undergoing general surgery in the state of Michigan. And what we saw was that nearly 25% of persons undergoing a discretionary elective hernia repair had a modifiable risk factor, namely a median BMI of 42, active tobacco use, or poor glycemic control. Not surprisingly, this was associated with increased rates of complication and discharge not to home, such as a subacute rehab facility. And these complications increased episode of care spending approximately $60 million for the entire state. And when you looked at the added episode and cumulative spending attributed to those significant risk factors, you also saw that that was relatively significant. The added spending attributed to any complication for BMI, for example, was approximately $1,300 per case, which really impacted to about $1.2 million a year. So I think the real question is, when you want to impact change, is I would assume that everybody would agree preoperative optimization is a good idea. And so the question is why are we not optimizing patients? Is this a knowledge gap in that we don't know that this is a good idea, or are we justifying our behaviors in other ways? And to answer this question, we then went and did a qualitative assessment across the state of Michigan using an implementation framework, the theoretical domains framework, so that we could create actionable implementation strategies based on these interviews. I interviewed approximately 21 diverse practicing surgeons in the state of Michigan with semi-structured interviews to really understand why people practice the way that they did. Again, the theoretical domains framework, which was used to understand individual surgeon behavior and motivation, really because we can then map it to behavior change techniques and design theory-informed interventions for identified practice gaps. And interestingly, 3 major barriers to preoperative optimization were identified. The first barrier was financial. Surgeons don't get paid not to operate. There's a loss of income, the perceived loss of referral from referring physicians, concerns on reputational damage if they're refusing to operate and they go see competitors, and malalignment of reimbursements. Some representative quotes from this say, "I'd love to stay that we're sticklers about it, but we're not. In this day and era of patient satisfaction, you send these patients out and they come back and say, quit smoking. They just go find somebody else and then they write you a bad review. So you have to balance that. Another surgeon said, in my practice, we don't stop for smoking or diabetes. We would still offer a repair. I don't get paid not to operate. The second two themes really focused on knowledge and resource access, mainly a lack of institutional infrastructure, and also a lack of knowledge about statewide opportunities for prehabilitation. And finally, practice patterns and organizational barriers really impacted, namely organizational expectations, local and partner practice, and really clinician autonomy. For example, at the big universities, you can kind of draw a line, but in the communities, I think we're kind of stuck with this. Another surgeon stated, I'm a very lazy surgeon. You should do what's easiest for you. If it would be easy for you, it would be probably easier for the patient. And finally, a final surgeon said, I don't read guidelines, I just make it up. So what does this all mean? I think preoperative optimization is a great target for change and a great target to improve the quality of patient care. Our goal is to optimize patients prior to surgery, and really the point of intervention are on those factors where we can really have great impact, namely BMI, smoking cessation, A1C levels, and pulmonary training. And we do have data, not just from the MSQC, but from other studies stating that if we did this, it would really decrease complications as well as episode of care spending and healthcare costs. We also understand, though, from talking to surgeons, that this isn't easy, and just telling a surgeon to do best practices isn't going to work if we don't address the multifaceted barriers that impede people from doing, quote, the right thing. And our data suggest multifaceted strategies are needed to change behavior and fill that gap between evidence-based practice and implementation. So an example of this, in terms of at least what we're doing in a state in an effort to improve outcomes, is first, we identified that surgeons really have little financial incentive to delay surgery. And this really suggested the potential for a financial incentive to align surgeon practice with patient optimization practices. In Michigan, we are lucky because we have a phenomenal relationship with our payer, Blue Cross Blue Shield. And within the next year, we will likely release a pay-for-performance metric circulating around patient pre-optimization. Second, however, is a little bit harder because those barriers related to knowledge and resources for optimization and organizational culture can be really hard to address. On the one hand, again, in our state, we're fortunate to have a preoperative optimization program which can be deployed across the state and register patients. However, we still have a lot of work to do to overcome organizational barriers, set referral patterns, and practice conformity. On this slide, we may also put out two other strategies. One, a provider-led training and learning strategy on how to deploy resources, and two, facilitation in different organizations to help providers overcome barriers that are not overcome by education alone. So in summary, preoperative optimization is important. Optimizing patients prior to surgery does and will improve outcomes. However, overcoming barriers to optimization really will require a multi-level strategy that will be dependent not just on the individual culture of an organization, but on the interplay it has in the local community, regional, and national. So I would encourage everybody to examine their own practices, see what they're currently doing, identify what barriers are in place, and work to change them. Thank you so much for this opportunity to present.